This is chapter 39, Geriatrics. So let's talk about the aging process and how it affects the body. So first thing is the cardiovascular system. This is the heart and the blood vessels. You already by now should be aware of what happens to your blood vessels as you age. You get atherosclerosis, you get hardening in the arteries, you get plaque buildup in your arteries. So there's a natural process where usually people, as they get older, they develop hypertension because the arteries just get unable to relax and contract, and there's just increased pressure in there. And this is why a lot of people of this age group are on hypertension medications like atenolol or propranolol or one of those ones. Now, when it comes to silent heart attacks, you've already been through the lectures about people having myocardial infarctions and angina pectoris and all that. And there are these very, very, very typical signs and symptoms of a heart attack. The problem is because of the aging process, these elderly people, especially elderly females, do not get those, or generally don't get those typical, I've got chest pain, it radiates to my arm and my back and that kind of thing. They get the vague stuff like I'm dizzy today. I don't feel well. I had one lady tell me that she felt like she had caught the flu. Like I think I caught the flu today, but in fact she's having a heart attack. I had another lady who every morning she would walk up this flight of stairs to retrieve her newspaper so she could have breakfast. And this went on for years and years. And then one day she walks up this flight of stairs and she gets winded. She gets short of breath while walking up this flight of stairs. Well, that's different. And so even though she had no chest pain, she had no dizziness, she had no nausea, there was nothing else other than now as she's walking up this flight of stairs, she exerts herself and now she's short of breath. She was having a heart attack. So the whole idea here is when you have someone in this geriatric elderly population and they have a history of maybe previous heart attacks or previous heart conditions, maybe they're treated for hypertension, maybe they're diabetics, maybe they have high cholesterol, they're treated for all those disease processes, and you have a person who's 79 years old who's now complaining of dizziness and shortness of breath, you've got to think this might just be something related to their heart. And it would be wise to either call in medics, maybe rendezvous with them possibly so they could do an EKG on this person. Or if that's not practical or the hospital's closer, take them to a cardiac care center, a STEMI center, just in case. Because you just don't know. And truthfully, if it's not a heart attack, if it truly is just the flu, and you've erred on the side of, for the benefit of the patient, no one would ever fault you for this. No doctor would ever yell at you for being cautious with these patients. So the respiratory system. So, as these people age, their lungs become less compliant. I guess you call it more brittle, I guess. The alveoli aren't quite as flexible, so they don't extend or expand with each ventilation as the person breathes. They probably also have a lot of them will have COPD. They'll have emphysema or chronic bronchitis. They might be on home oxygen themselves, maybe 2 liters via nasal cannula. And because of the aging process and maybe even the smoking COPD process, they do have a diminished or absent cough reflex. Now, every day that we are alive, we breathe in all kinds of particulates into our lungs, and we have a mechanism that allows us to cough this gunk out. Well, they can't. So they breathe in bacteria, they breathe in viruses, those are retained, and this is why they're so prone to respiratory infections like bronchitis or pneumonia. So a lot of times you'll encounter elderly people with wheezes and bronchi and those weird kind of sounds in their lungs. They might have a fever associated with this, especially with pneumonia, and their oxygen saturations will be lower than normal. So you have somebody who has COPD, let's say they're emphysemics, they caught pneumonia, and even though their normal oxygen saturation level due to their COPD is probably 92%, now their oxygen saturations are 88%. because of this new onset pneumonia that they acquired. Again, you treat them symptomatically, oxygenation, possibly bag valve mask ventilations if that's, if this person's really seriously short of breath or having problems breathing. But again, you just have to think about elderly patients just in general, where if you need to deliver oxygen to them, just realize that their lungs are less compliant. So if you're doing bag valve mask ventilations, don't be as aggressive because you can actually pop their lungs. And realize the lungs transmit oxygen to the bloodstream less effectively or efficiently than a younger person. So it might take a little teeny bit more oxygen, maybe bump it up a teeny bit to get some kind of effect on this person. So neurologically, a lot of different things happen. Sense of taste and smell are lost over time, or gets less anyway. They have vision issues, obviously, macular degeneration, and they get cataracts and glaucoma, so they have vision problems, which is obviously a big problem for a number of reasons. They develop neuropathy. Neuropathy, usually it's in their lower extremities, but sometimes it will happen in their upper extremities as well. Their nerves become numbed, so they can't feel their feet, so they're walking. And if you ever think about when you walk, you feel the ground beneath your feet, and it helps you to maintain your balance and maintain your body's equilibrium when it comes to standing. These people, they can't really feel their feet very well. They can have pins and needle sensation as well as numbness. So that can be a problem as well. So they lose their balance. They're more prone to falling. Now, when it comes to brain mass, as you age, the brain shrinks in size physically. And as we already know, the cranial vault is a fixed size. That's the bone, and the bone that makes up the part of your skull, right? So if the brain shrinks within this fixed cavity, then if a person were to fall and hit their head, that brain could shift and move around much greater than it normally could. And this is when you get elderly people who have internal bleeding. They hit their head, their brain shifts suddenly in one direction or the other, that contra coup response that I'm sure you remember from your head injury lectures. And then blood vessels get torn, and they get subdural hematomas, very commonly, sometimes even epidural hematomas. And if they're on blood thinning medications, maybe like a Plavix type of medication, this is much worse for them. So anytime you have an elderly person who's struck their head, they should be seen at a trauma center. Maybe not as a trauma patient per se, not as going into the trauma room, but at least take them to a trauma center so their brain can be scanned to make sure they aren't bleeding internally. Now, obviously, if this person's hit their head and they're unresponsive, then of course they would go to a major trauma and they go into the trauma room. But you guys get the idea with this. So anytime someone falls like this, we're always concerned about that shifting, moving of the brain around inside the cranial vault. Now, speaking of the brain goes through chronic issues as well as acute issues. Dementia is a chronic long-term disease process, and actually a subset of that is Alzheimer's. I'm sure everyone's heard of Alzheimer's disease and how the plaque develops and causes this gradual destruction of your brain and over the period of years and years and years. Well, dementia is kind of like the same idea. This person, it's chronic, it goes on for a long time, and there's really no cure for it. Now, delirium is different. Now, when someone is delirious, it's usually from a medical problem. Someone who's hypoglycemic and disoriented is in a state of delirium. Someone who's acting out because they have a high fever, they're also delirious or in delirium. So usually delirium comes on fairly rapidly and it's associated with some kind of medical condition that can be curable or reversible. So you treat them symptomatically, you restrain them if necessary, you cool them down if they're having a fever, whatever the situation might be. But again, in the end, when they go to the hospital and get treated, they come out of it and they go back to their normal state. Now, again, Alzheimer's disease, kind of talked about that already, but I wanted to point out that there are these stages of Alzheimer's, and everywhere it starts out pretty much very mild, where the person is diagnosed by a physician and they're told they have Alzheimer's disease. They're still oriented at this time. They probably have a little bit of forgetfulness, but this gets worse, and pretty soon they forget the names of their family members. They don't know where they live. They don't know what year it is. They go through a nice stage. That's all I can really call it. There's a period where they're just really nice and friendly, and they want to hug everybody and love everybody. And then over a period of time, they develop at some point this nasty stage where they get really angry and really violent, and they start screaming and yelling and trying to attack people. And this, I mean, I'm talking, period of years here. It's not, months. And so where depending on where you meet or interact with this Alzheimer's patient is going to depend on how you approach them. If they're really friendly, loving stage, they're pretty easy to deal with. Sometimes in the earlier phases, they have lost their short-term memory. So you might have to repeat things over and over again, like where you're going and the day of the week and things like that. In the violent stages, they're actually very dangerous. They can scratch you, attack you. They're very strong. I actually had one nurse tell me that she worked at a convalescent home, and she was talking to an elderly gentleman in a wheelchair, and they were having a great conversation. And this Alzheimer's patient, who was a female, was sitting next to the gentleman, and even though they were unrelated, the Alzheimer's lady thought that was her husband and thought that the nurse was hitting on him, and she attacked the nurse and just basically dove out of the chair and just linebackered, so to speak, the nurse. So you just got to be really careful about these patients in that particular stage. Eventually, what happens to these Alzheimer's patients, and you guys, if you work as EMTs on an ambulance in the county of San Diego or anywhere else, you're going to go to a convalescent home and you're going to encounter the end stage Alzheimer's patient. By this time, the people are deeply into a coma. Their brain is deteriorated to the point where they're breathing. They've got a pulse, but they're completely unresponsive. And what happens is they start to contract, or they get contractions. So you find them lying in bed and they're curled up like a baby. Their arms are flexed, their legs are flexed, and their arms and legs are locked. You can't move them. They're completely frozen in this position. They're still alive. They're still breathing. They're fed through a tube. It's pretty sad, actually, why they just don't let them pass on. But you will be transporting these patients in this end stage, and then finally the brain deteriorates so much that they eventually die. Happy times. Gastrointestinal system. My biggest concern here as an EMT, they do get malnutrition issues because they just get tired of eating, get tired of cooking. Maybe there's some monetary thing where they can't really afford food, and just nutrition's kind of an issue for the elderly population. And we know that the liver and the kidneys both, their function, deteriorates over time. The big thing for me is the peristalsis. So when you eat food, we have this peristaltic wave that pushes the food through our gut, and we obviously eliminate this through our stool going to the bathroom. So a big problem with this with the elderly population is because this peristaltic wave is slower than normal. These people don't eat quite as well as they should. They probably don't drink enough liquids to maintain any kind of hydration. They're really prone to constipation. And constipation can lead to impaction. And impaction can lead to ruptured bowel, which can lead to sepsis and even death. So constipation in the elderly is a big problem. Especially if it's chronic and it goes on for days and even weeks sometimes. They need to be manually or digitally relieved of that constipation sometimes by the doctor, of course, not by us. So the endocrine system, these are our hormones. Some hormones go down, some hormones go up, depends on the circumstances. When it comes to the female population, they go through postmenopausal phases, or they go through menopause, and their female hormones change. They get osteoporosis from this. They get mood swings and all different types of other problems. Hopefully, they take some kind of estrogen or progesterone medications to help minimize the side effects, the symptoms, the hot flashes, and all that. Guys, even though guys are in denial, but guys sort of go through also a menopausal stage as well, in the sense that there's some indication that guys who go through a male menopause phase, their hormones change. Have you ever noticed elderly men, older men, their hair kind of leaves their head and shows up on their shoulders, and they're in their ears and all that? It's kind of a sign of the changing hormonal levels. So we all go through the same thing over time. The whole idea here is that with the endocrine system, remember this is also the pancreas. So the pancreas controls our blood sugar. So you have these increase and decreases in hormones depending on whether you're male or female, in both cases. You do get this drop in insulin or response to insulin. And of course, this leads to elevated blood sugar levels. A lot of times people over 65, they start to develop type 2 diabetes. And sometimes they're not aware of it. So maybe this elderly person doesn't like doctors, they're afraid of the doctors, so they haven't seen a physician for a couple of years. And now you get there and they're disoriented, they're breathing rapidly, and you're like, wow, this is really weird. What's going on here? And you take their blood sugar and it's 700 or 400 or whatever it might be. So this person is an undiagnosed type 2 diabetic that you just diagnosed essentially. So she needs or he needs to go to the hospital. They need to start them on some insulin and get them on some kind of oral hyperglycemic medications like glyburide or Glucophage, or one of those ones out there, brands out there that they sell so many. Avandia is another one. So the biggest problem with this is we encounter people that are hyperglycemic, or maybe they know they're type 2 diabetics, but they just don't take their medications, or they can't afford their medications, and their blood sugar rises. And of course, the opposite can happen. It's pretty rare, but remember the elderly population, and not every old person is feeble, not every old person is forgetful, but it does happen rarely. But it does happen where an older person will take their Avandia in the morning with their coffee, and then an hour later they go, did I take my pill today? Gosh, I better take another one just in case. Well, those hyperglycemic oral medications like Avandia and glyburide, they're super powerful and they last 12 hours. So you take a double dose, what happens is it drops your blood sugar dramatically. And now you're hypoglycemic. Now you're altered and unconscious. So it's pretty rare, but it does happen. I've seen it a few times out in the field. But predominantly what you see with these elderly people is hyperglycemia due to unrecognized type 2 diabetes. So musculoskeletal system, like I mentioned before, the females get osteoporosis. Guys get it as well, but not as severely. The bones are very brittle, very light, very easily fractured. So you have an 80-year-old person who falls on the ground, there's a good chance they're going to break their femur, the proximal end of their femur, or something in their hip, or somewhere else. If you were to have the same fall, you'd probably bounce and get up and get back on your skateboard. These people, they don't get up, unfortunately, because these bones are so brittle and the density is so light. They have, of course, the kyphosis. They got the kind of the humpback thing going on, which makes it difficult for us to get them into spinal motion restriction if we need to do that. And that's why it's so nice to just put a C-collar on them now and sit them up or pad them. You still need to pad the gurney or pad the backboard. They can have chronic pain with motion or movement due to arthritis, in their joints and all that. So this is all kind of connected together. The idea is you have someone who's fallen, an elderly person, and they're fallen, and they're stable. The trick is to move them slowly and carefully with minimum, aggravation of their injury or even their chronic issues like their chronic pain. We don't want to make them hurt more. So there's no need to rush on these patients. They're not critical. They just need to be stabilized and transported carefully. Now the renal system, again, like I mentioned, the kidneys, they just don't function quite as well. These patients, because of the fact they don't drink a lot of water, because of their diet, they do get dehydrated, especially if they're diabetics and they're hyperglycemic. Remember, one of the symptoms of hyperglycemia is polyuria, so they pee a lot. So they get dehydrated from that, from the hyperosmolar non-ketonic syndrome that I'm sure you remember from your diabetic lectures. Now, when it comes to signs and symptoms of dehydration in the elderly, look inside their mouth. If their tongue is dry, if the mucosa inside their mouth is dry, they're dehydrated. Now, you can't really do much about this in the field. If their best thing would be to do is get them to a hospital where they can get intravenous fluids, or if the medics are closer, then the medics can come and start a line and give them fluids intravenously to help that rehydration process. But the sooner the better, because they are super dehydrated and their electrolytes get really thrown off by this process. Now, because the liver and the kidney function is decreased, and because these patients take a lot of medications, and I don't be surprised when you go out in the field and you go pick up grandma and you ask her, so ma'am, what kind of medications are you on? And she hands you a whole shoebox full of medications. So I take these. That's the problem. And another big problem with this is that a lot of times these patients take 5, 6, 7, 8, even 10 different drugs a day, and they don't know what they're for, and they don't know why they're taking them. So either the doctors aren't being good at what they do and explaining to the patient why and what they're taking, or the older person doesn't really care, or whatever the combination of problem is. There's this drug ignorance. And so if they're taking all these different drugs from all these different doctors, not every drug interacts well with another drug. So they take one drug from one doctor and it's actually contraindicated for the other drug the other doctor took, and you put them together, it's a problem. So remember, when the drugs themselves, when they pass through the body, they're eliminated either through the liver and then out into the stool and out through the feces, or through the kidneys and out through your renal system. So if either of these or both of these systems have decreased function, then it's harder for them to eliminate these lipid-soluble and water-soluble drugs. So they kind of build up inside the system anyway, even if they don't make a mistake with how much they should take every day. So a lot of questions I ask, I go, any new medications you started on, anything different today? They might say, well, my doctor increased the dose of my hypertension medication, or the doctor decreased the dose of my other medication, or I just started on this brand new medication yesterday and now I don't feel well. So a lot of times these calls are related to medication issues, either underdosing or overdosing. I just had a gentleman recently, he called for nausea and vomiting, and then it turns out that the day before he started on an antibiotic. And one of the major side effects of those drugs is nausea and vomiting. So, it's really important to ask what drugs you're on, and are they new drugs, or are they a new dosing of those drugs? Now, when it comes to the skin, all I got to say about this is the skin it becomes a lot thinner. It's much more fragile. It's more prone to sores and ulcers and skin tears. You got to be much more careful with these patients, and of course with infections. And ultimately, if the skin is thinner, there's less cushion, there's less insulation. It doesn't work quite as well. This also affects their ability to control their body temperature. So now you have an elderly patient. You ever go to your grandma's house and she's got 9 sweaters on, and you walk in the door and it feels like it's 110 degrees in there and she's freezing? It's because her temperature control system in her body is skewed because of the aging process. And for her, she's really cold. And this is because she can't control her body temperature very well anymore. So she has to compensate by the extra heating system and the extra clothes and all that great stuff. So you think about it, it makes them more prone to becoming hypothermic or hyperthermic, depending on the circumstances. And these are environmental, meaning they're caused by the environment that they're in. So be aware of that. So have extra blankets. Older people are always cold. And if you're cold, they're freezing. So turn the heater up in the back of the ambulance, put extra blankets on them, keep them warm, cover their tootsies. Their feet get cold, their hands get cold. Cover them up to their neck. Tuck them in. It will help a lot for them, and they'll feel like you really care, which you should, obviously. Now, there's other types of calls we go on. I want to talk about briefly, and these are what I call them social service calls. So what will happen is, like, there'll be an elderly person. Let's say there's an 80-year-old male, and he lives by himself, or it could be a female, whatever, right? The neighbor notices they hadn't seen Bob maybe in a few days, so they call 911, and the police come out. And the police knock on the door, and there's no answer, and they look in the window, and the inside of the house looks like it's a hoarder's house. It's just destroyed inside. It's piles everywhere. It's filthy. So they break in, they call 911, and they find this person lying on the kitchen floor between these piles of magazines. And they're disoriented. Maybe they got some injuries about them. And so you'll get called out to assess and transport this patient. Now, this is really a social issue. So this is a failure to thrive issue. This person, if you were to look in their refrigerator, they would have no food. There's maybe no running water in the house. You'll find, I've found dead cats, skeletons of dead animals in these houses. This person has been living on who knows what, and this is what's called failure to thrive. They're usually very dehydrated. Malnutrition is a big issue with this, and they have to be taken to the hospital even against their will. The police are there usually, so that's kind of helpful. That's why anytime you go to a person's house, an elderly person's house, and you're treating them for whatever reason, it's a good idea to do a complete scene size up and get an idea, like, is the place fairly clean? Are they taking care of it themselves? I'm talking about people who live by themselves, right? Just notice, is there food on the table? Does there appear to be, the kitchen seems to be functioning and all that? If not, then maybe you might want to consider calling social services. Maybe when we get to the hospital, you can discuss this with the physician, and they can hook this person up with social services. Suicidal ideations are very, very common in the elderly, especially if they have some kind of terminal disease. So they want to kill themselves, and they do. They have all those medications we talked about, all those prescription medications that the doctors gave them. Half of them are fairly dangerous prescriptions, if you take too many of them anyway. So you'll see this not so often, but I would say a lot of these accidental overdoses that we run on are not accidental. That's just my opinion, of course. And a lot of times people will just call because they're lonely. I go on a lot of calls where a little old lady, little old guy, they call us because they got no one to talk to. They call, they say something on the telephone to the 911 operator. I don't feel good today. I'm having chest pain. I feel dizzy. But in reality, what it is, they just need to talk to somebody. They need a road trip to the hospital, basically. And that's totally fine with me. I understand completely. I'm more than happy to accommodate them. And of course, you've already learned about abuse and neglect. So abuse would be something physical, like the person is beaten or restrained or sexually abused. Neglect would be not feeding them or not giving them their medications or not cleaning them. Any of that stuff has to be reported to the County of San Diego within that 36 hours that you've already learned about. And because they're on so many medications, especially narcotic medications, pain relievers for chronic pain like arthritis and other types of pain, I go on a lot of narcotic overdoses in the elderly population. This is like codeine or T3s or one of those common prescription narcotic medications. Norco, those are another common one. And so again, this is just going to be you might see the pinpoint pupils as long as they don't have cataracts anyway. You had the hypoventilation, the altered mental status, and it's bag valve mask ventilations and the Narcan, and that's again, remember with the Narcan, because this is a comfort care issue, you would only hopefully just give enough to get them breathing again, not the whole dose, unless you absolutely have to. But that's, it's going to be your call on that. And then ultimately, when it comes down to all of this, is your assessment process. If you don't approach this patient in a way that you develop rapport with them, if you don't allow them to trust you, and this is the biggest problem that I see in the field, and I understand completely, there's a generational gap between someone who's 22 and someone who's 82. Entirely different life experience, grew up in an entirely different world, entirely different view of the world, and you have this young person who has the inability to develop a communication with this person. You're not going to be able to assess this person properly. You need to approach this patient, get down at the level of their eyes, make eye contact with them, hold their hand. Hi, I'm John. I'm here to help you. What's happening? How can I help you today? You need to exude this aura of trust, and you basically make this person feel like they are the most important person in the world. It's really important that you do this. And realize too that elderly people, they have fears, they have concerns. One of the biggest fears is loss of their independence. You represent, as an EMT, you represent maybe a drive to the hospital, and the hospital is not a happy place, especially for the elderly populations. And they've been there before, they know what it's like, and they don't really want to go back unless they absolutely have to. So they would rather not. So if you develop really good communication with them, and you gain their trust, and you explain, well, because of your situation today, if you don't go to the hospital, I'd be really concerned about it. Your family would be concerned. Somehow express to them your concern, maybe their family's concerned, maybe their loved one's concerned about them going versus not going. Show your concern for them, your interest in their situation. It's really important. Now, when it comes to physiological differences, we talked about all this stuff earlier, but because these people have chronic hypertension and they're treated for the chronic hypertension with medications like atenolol, because they have heart conditions, possibly because they have respiratory difficulties, because they have poor stores of sugar, because of their liver not functioning quite as well, and they're already chronically dehydrated, and all those things add together. When this person does get seriously ill or seriously injured, they cannot compensate as well as a young, healthy person. And also, because of the medications that they're on, you might miss the fact that they're in compensated shock when you get there. Remember, if you remember back from your shock lecture, I'm talking about like hypovolemic type of shocks predominantly here. But if you look back in your shock lecture, one of the very first things your body does to compensate for shock, for blood loss or fluid loss, is to raise your heart rate. 110, 120 beats per minute. Well, if you have a person who's 75 years old and they're on a beta blocker medication like metoprolol or one of those hypertension medications, what that does is it's a beta blocker. It blocks beta 1. It keeps the heart from pumping faster. So this person's trying, the person's body is trying to compensate. It's sending out the messages to try to increase their heart rate to compensate for their blood loss. But it can't because it's blocked by this beta 1. So now you got a problem. So you get there and their heart rate's 80 when it should actually be 120. So you might miss the fact this person is going into shock. So you have to kind of rethink when you're assessing elderly people. You got to rethink like what's the norm. If you go on a call and there's a car accident and there's a 75-year-old female inside of a car who's been struck by another vehicle, and her heart rate's 80 and her blood pressure is 110/70 and her skins are pale, warm, and dry, you might think, wow, she's fine. Well, but think about it. She's on a beta blocker. She's on one of those beta blocker medications. She's also, turns out, she's on Plavix, which is a blood thinning medication. Turns out she's bleeding internally. But initially, you don't think she is because her blood pressure is what you would consider to be the norm for you or someone younger anyway. 110/70 would be normal for someone in their 20s, 30s, or 40s. For her, she's hypotensive and she's going into shock. So again, these presentations can mask this compensated shock phase, which we can miss on these patients, and they do crump. They do fail really quickly. They're literally like children in that respect. They have poor stores of energy, poor stores of oxygenation, and they try to compensate, but they crash pretty quickly once they lose those stores of energy. And remember, going back to what we talked about earlier, the medications that they're on are really important to know about because medications can affect their ability to compensate for these illnesses and injuries, like I talked about. And other chronic diseases kind of compound on what's going on. You have someone who's been in a car accident and they've got diabetes, they got hypertension, they got high cholesterol, and they've had previous strokes. All those things add up to them having less chance of surviving or doing well anyway when it comes to an outcome from their injuries. So you really need to take off your thinking cap and put back on your elderly thinking cap when you're assessing these patients, how you approach them, how you talk to them, build that rapport with them, and factor in physiologically and when it comes to medications and chronic diseases and all that, work that all together to get an idea like what's normal for this person and what's changed, what's different, what's wrong with this picture. And then again, treat them very suspiciously in the case of they can be really sick when they don't appear to look very sick, and then treat them aggressively when it comes to oxygenation and perfusion. And I think we're done with the chapter.